in the 2010s, the resurgence of infectious diseases. We are so glad you could join us today, those of you here in person and those of you joining us virtually. My name is Paige Hornsby. I'm a faculty member in the Department of Public Health Sciences in the School of Medicine at the University of Virginia. I am also the advisor for the Gamma Pi chapter of Delta Omega. And Delta Omega, for those of you who may not know, is the Public Health Honorary Society, founded at the Johns Hopkins School of Hygiene and Public Health in 1924. The society was created to recognize students, alumni, faculty, and honorary members who demonstrate excellence and commitment in their pursuit of a public health profession. Now, those math wizards in the room might notice that 1924 to 2024 is 100 years. This presentation is part of a webinar series celebrating the 100th anniversary of the Society. The series highlights important public health events, developments, and achievements in each decade since the 1920s. I encourage you to explore the previous webinars in the series. They've been recorded and are available on the Delta Omega website. So welcome again to the final presentation in this series, in which you will hear from a panel of UVA infectious disease experts who will share their knowledge and experience grappling with some very important infectious disease challenges during the decade of the 2010s. The panelists will be introduced by our chapter president-elect, Jana Pushkin. And after the panelists speak, we will have time for questions and further discussion. And please join us outside the auditorium at the end for some refreshments. Jana? Yeah, it's all yours.
Thank you, Dr. Hornsby. And good afternoon, everyone. It's great to see you all here. My name is Jana Pushkin, and like Dr. Hornsby said, I am the president-elect for UVA's chapter of Delta Omega. I'm also the newborn screening epidemiologist at the Virginia Department of Health. Today, we are all very fortunate to have our three presenters here to share their experiences and lessons learned working in public health and medicine through various infectious disease events of the 2010s. Our first speaker is Dr. Frederick Hayden. Dr. Hayden is the Stuart S. Richardson Professor Emeritus of Clinical Virology and Professor Emeritus of Medicine at the University of Virginia. From 2006 through 2012, he also served as a medical officer in the Global Influenza Program at the World Health Organization in Geneva and as an influenza research coordinator at the Wellcome Trust in London. Dr. Hayden has contributed to the development of 7 influenza antivirals and 2 vaccines. And during the COVID-19 pandemic, he collaborated with colleagues in China to conduct the first controlled trials of candidate antivirals in hospitalized patients. Today, Dr. Hayden will be speaking about his experience with H1N1, influenza events, and antiviral therapy for respiratory infections. Our second speaker is Dr. Kyle Enfield. Dr. Enfield is an associate professor of medicine at the University of Virginia, where he completed his residency in internal medicine and his fellowship in pulmonary critical care. His research interests include infection prevention and epidemiology in intensive care units, environmental influences on chronic lung diseases, ICU outcomes, and hospital outbreaks. Dr. Enfield will be presenting his experiences and insights into preparing for the Ebola outbreak. And finally, our third speaker is Dr. Norman Oliver. Dr. Oliver served as Virginia's State Health Commissioner from 2018 through 2022. Prior to joining the Virginia Department of Health, Dr. Oliver was the chair of the UVA Department of Family Medicine. Dr. Oliver currently teaches in the UVA MPH program. And today, Dr. Oliver will be sharing his reflections on the role of public health in infectious disease events like COVID-19, as well as his experiences working at the Virginia Department of Health during the pandemic. So with that, everyone, welcome our speakers, and I'll hand it over to you, Dr. Hayden.
Thanks very much for that kind introduction, and also thanks to Paige Hornsby and Tess Robertson Neal for the opportunity to be with you. Congratulations, of course, to Delta Omega and the Gamma Pi chapter here at UVA for celebrating your centennial. I really thank Paige because this invitation stimulated me to reflect on a very consequential period in my own professional life. During my 2.5 years in Geneva working at WHO, I was engaged in a number of different types of response, but my primary task at WHO was to help establish a collaborative research network in Southeast Asia to help address clinical studies of zoonotic H5N1 infections, which were occurring at that time. Again, this is avian H5N1 that was causing then hundreds of cases with a mortality of about 50%. And we'll get back to H5N1 later. This ultimately led to the formation of what was called the Southeast Asia Influenza Clinical Research Network, funded by NIH, and it undertook studies in hospitalized patients that helped determine the efficacy of the anti-flu drug oseltamivir in these patients, but also determined that there was a problem with the emergence of drug resistance to oseltamivir in some of these patients, and that was often associated with mortality. The network also helped establish high-quality diagnostic labs in the region, which continue to function to this date. One aspect of working at WHO is that it's common to have to change direction because of new events that emerge. One example, which I was personally involved with, was responding to the emergence, again, of oseltamivir-resistant seasonal H1N1 virus. This started in late 2007. The virus was first detected in Norway and then spread globally over a period of months. And these viruses contained a neuraminidase substitution that basically confers complete loss of activity in people of oseltamivir antiviral effects. This virus continued to circulate, causing many infections until it was replaced by the 2009 H1N1 pandemic virus, which fortunately was susceptible to this particular drug. And this just is an example of the unpredictability of influenza infections. And as you probably well know, this is due to both the segmented genome of the virus, so that it can, when there's dual infection within a cell, it can swap gene segments, but also because it lacks a proofreading mechanism and there are frequent mutations, so that there can be the emergence of new virions. If you look back historically, we had pandemic flu emerge in Asia, an H2N2 virus called the Asian flu in 1957, and then the Hong Kong flu in 1968, which was an H3N2 virus. And both of these viruses acquired new genes from birds. And this was due to reassortment events, with swine perhaps as the mixing vessel. So we need to pay attention to what happens in pigs. And that includes what's going on right now with regard to the avian H5N1 epizootic. So in contrast, the swine origin pandemic in 2009, which is what I was asked to talk about, emerged in North America, first detected actually in Mexico, and then shortly thereafter in the US. And this virus contained genes of swine, avian, and human origin. So it was a triple reassortment. The virus, again, very rapidly spread globally. By June, there were a total of 73 countries affected, and the WHO declared a full-fledged pandemic, which lasted just over a year. But just bear in mind that that virus itself, of course, is no longer with us, although its progeny continued to circulate and cause illness, hospitalizations, and deaths worldwide frequently, because it's part of our seasonal virus repertoire now. So if one looks back again at the 2009 pandemic and its impact, it was much less severe than the preceding pandemics, much more like, in terms of total mortality, a seasonal event. During the first year, the CDC estimated in the United States we had about 61 million cases, 275,000 hospitalizations, and just over 12,000 deaths in this country. But what was really different was that it was the age-related impact. So that according to, again, CDC data, nearly 90% of the deaths occurred in those less than 65 years of age. This is much different pattern from seasonal influenza. Children and working adults had increased risks of hospitalization up to 7-fold higher, and death up to 12-fold higher compared to seasonal influenza. Whereas adults who were 65 years and above had a much lower risk of having problems with this virus, about 75% lower risk of mortality. So multiple factors, as you might imagine, contributed to this. Part of it was differences in viral virulence, but also, of course, prior immune experiences. So that very few young adults had antibody that was specific for the virus, whereas about a third of the older adults did. Vaccines did come online that were strain specific and may have made some difference, but really they were quite delayed. Didn't really become available until November of 2009. What also made a difference was that this was the first pandemic in which there was fairly widespread use of antivirals, particularly oseltamivir. The pandemic virus, as I said, was susceptible to this agent and other neuraminidase inhibitors, but was resistant to the older class of drugs, the adamantines. Fortunately, the current avian H5 virus that's circulating in cattle is susceptible to both of these classes of drugs, as well as to the newer agent, baloxavir. There were lots of observational data published on the effects of treatment with oseltamivir during the pandemic. The largest of these was the PRIDE study, which accumulated data from, I think it was 30,000 hospitalized patients, multiple countries, and in this cohort, large cohort of patients, there was about a 10% mortality. If oseltamivir was used in patient care, mortality was reduced by about 20%. If it was used within 2 days of symptom onset, mortality was reduced by 50%. So a very substantial impact. That included even in ICU patients and also importantly in pregnant women who had an excess mortality. Indeed, there were hundreds of maternal deaths in this country. In contrast, in a country in Japan and several other countries where there was very early and aggressive use of antiviral drugs, and specifically in Japan, there was no maternal deaths in the first year of the pandemic, and very few pediatric deaths as well. So just to opine for a few minutes about the importance of collaborative science. Following the first year of the pandemic, the heads of several international funding organizations asked the Wellcome Trust while I was there to assess how to improve influenza pandemic preparedness and response. And this is the theme that continues today, of course. We had a series of expert meetings that ultimately led to a new entity called the International Severe Acute Respiratory and Emerging Infection Consortium, ISARC for short. This was a global federation of about 60 investigator-led clinical research networks, mostly ID, infectious disease, and critical care, and has continued to function to this date, having done studies in COVID, dengue, Ebola, as well as other infections. The inaugural chair of ISARC was Jeremy Farrar, who I first met in Vietnam, again, as part of the H5N1 response. At that time, he was leading the Wellcome Trust Research Center in country. And it's really been one of my great professional and personal privileges to have continued to interact with Jeremy for the last 20 years. He served a decade as scientific director of the Wellcome Trust, which is one of the major international funders for infectious disease research, and then moved last year to become the chief science officer at the World Health Organization. So, of course, now he also is heavily involved with trying to determine research priorities for pandemic preparedness. And this really highlights one of the weaknesses with 2009 pandemic response, because we really didn't have completion of any rigorous studies on how to improve clinical management. I mentioned a lot of observational data were collected, but specifically there were no randomized controlled trials completed that addressed antiviral use, immunomodulator therapy, or other kinds of therapy to help improve outcomes, especially in severely ill patients. And this, of course, really contrasts with what was done in the COVID response, fortunately, where these large platform studies were able to determine different interventions that really made a difference in a positive way, and also discard things that were useless, including, for example, hydroxychloroquine. With some of these insights with COVID are now being re-examined with influenza by several of these large platform trials, including REMAP-CAP and recovery investigators. So for those of you who want to read about the 2009 pandemic in more detail and the issues involved with the response, I'd refer you to a very fine New England Journal article published by Harvey Feinberg, who was then at the Institute of Medicine in 2014, that helped address the lessons learned during the response. There were many that were positive, but he also pointed out that while, and I quote here, although the WHO is the only global agency with legitimate authority to lead the response to a pandemic, it is burdened by a number of structural impediments. And I certainly saw those when I was working in Geneva. Oh, that's the time I have to stop, but I leave you with that thought. Please, if you're interested, go read Harvey's paper. Thank you.
Yeah. Thank you.
Probably not quite as well prepared with something that I'm like here. Apparently, may not be loud enough. Okay. Like I said, I was introduced, my name is Kyle Infield. I'm a critical care doctor, which kind of makes me an aberrancy sometimes when you think about public health. Most people don't think about the ICU as a place where public health comes from. But I'll tell you that in the decades leading up to 2010, the one thing that I learned and that has carried with me is there's no lost opportunities to learn new things. I was in my undergraduate career. I watched this really cool movie called The Hot Zone. It's actually a really bad movie. Don't watch it. It's got horrible acting. The special effects are bad, and almost everything about it is wrong. But I was like, what's this epidemiology thing? It's a word that I'd never heard. I grew up in Oklahoma. It's a different area of the world. And so I figured I had to go to medical school to become an epidemiologist. That is what I learned from the movie The Hot Zone. And then I started medical school and decided that it was the worst place in the world to be. I did not like it at all. And before they let me quit, they encouraged me to look at some things. And so I spent some time at the World Health Organization where I learned about public health. It was a great experience. My printer was named Ebola. And that became part of my life. The printer down the road was yellow fever, and there was a lot of humor there. But when I came back, I kind of had a different idea of what I wanted to do. And I actually really came to residency with this idea that I was going to go into public health. I was very interested in air quality and how that influenced health. But there was just a small problem is that clinically, what I loved doing was being in ICUs. And so I decided to pursue, after a while, a pulmonary critical care fellowship. I figured I could blend something in here with some public health thing, not really knowing what this was going to lead to. And in 2009, there was this epidemic of influenza, and I happened to be a fellow at the time who knew about epidemiology, and so everyone was very happy to have me counting. That's what I did a lot of, was counting and making spreadsheets. I'm actually really good at Excel. I can make an Excel spreadsheet really fast and to document things. And at the same time, I got to know a gentleman here at UVA named Barry Farr, who was a hospital epidemiologist. Barry mentored me for a while and really encouraged me to sort of pursue some things. We kind of lost touch for a little bit. And then the hospital epidemiologist at the time at UVA was stepping down. And my boss, John Truitt, said, "Hey, Kyle, would you like to do this thing?" And I was like, "This is great. I can blend some epidemiology, some public health." There were problems with infections spreading through our ICUs. I thought I could do some really good work here. And then he said, "Oh, by the way, we had this outbreak of hepatitis B. And since you've studied outbreaks before, could you look at this too?" And I think I'm probably the only pulmonary critical care attending who has a publication about hepatitis B with the CDC. But again, it's one of those things where like there's no bad learning that happened here, because it was not that long after where Kosi Sifri, who was the hospital epidemiologist, and I were talking, and we were like, we're both, it would be really interesting to at least experience one real, kind of scary pandemic in our lifetime. I regret those words often. And in 2014, I think that's going to be right, there was the beginning of the spread of Ebola from Western Africa to around the world. It is very hard to think about that time now because there was a lot of naivete that we experienced, believing that this would be a disease that would rapidly halt itself and not spread to other countries. We didn't really truly understand the impact of the globalization of travel and how that can make things spread from country to country very quickly. And I will say that I think this is part of our pandemic response that we still don't completely fundamentally understand, that there is about a 12-hour connection between anywhere in the world and anywhere else in the world. And by the time you do a couple of degrees of separation, you realize that what is happening now in Sudan or in Venezuela or anywhere else can and will impact us, and we don't always think that way. So when cases started developing of Ebola in England and also in some of the Scandinavian countries, there was this question of what should UVA do, and Kosti and I made a plea that we at least needed a plan. And luckily, we started making on a plan because about 2 months later, the CDC said, "You guys need a plan," and we were kind of ready to go. And so we created this unit we call the Special Pathogens Unit. So the other lesson I can tell you, besides the fact that everything you can do is important, be careful how you name things, because the shortened version of Special Pathogens Unit is SPEW. And that has stuck with us. And no one really wants to work in this SPEW because it sounds bad. But we needed a space that we could virtually set up that would be able to contain highly transmissible diseases. And it's fortunate that when the UVA built the current location for the MICU, we had enriched for one section to have negative pressure rooms. And that is important because while treating the patients is paramount when we think about emerging infectious diseases and pandemics, from my standpoint, the critical thing that we often forget is that if our healthcare workers become ill or contract disease, we will lose the ability to care for our patients. And this was demonstrated very clearly in the Ebola response when, in a state of fear, nurses in Texas tried to develop their own methods for infection control and ended up contracting the disease, Ebola themselves. And so that led to a lot of things at UVA that we embraced through the COVID pandemic. The first one was there is no emergency in a pandemic. And the reason that we preach this to our staff is that you have to take care of yourself before you can take care of the patient. And so you have to slow down, and particularly in highly infectious diseases like Ebola, you have to make sure that you are protected going into the room and you're protected coming out of the room, because it's not just putting on the safety gear, it's taking off the safety gear. Now, in the developed countries, we're in a much better state. If you take care of Ebola patients in Africa, it's a hot environment. They have wonderful suits that they put on that are semi-coolish, but people lose multiple pounds of weight every time they take care of patients. We measured the body weight of our nurses with their permission, and we did not disclose this before and after. And people were losing, between 2 and 4 pounds after being in the room for about 2 hours. Because of the protective equipment that we were putting on. I also made this mistake of demonstrating at one point in time that the equipment was robust enough that you could do burpees in it. But then they said, no, you can't rip off your equipment. You have to take it off the correct way. And I've never been so hot. And it's a good lesson in that as well. So the special pathogens unit developed at UVA, and we ended up actually publicizing some of our response. We took care of several patients that were under investigation. We were lucky we did not actually have an Ebola patient. We did have a rabies patient. That's completely, which was another interesting story. But we had lots of people that came in with diseases, and it taught us a lot of lessons here about what we need to do. One is that all of these diseases provide fear. Even in the 2009 H1N1, despite the fact that people over the age of 65 were relatively healthy, a pandemic generates fear in the public. And we see the implications of that fear. When it was flu, it was a fear that we knew. When it was Ebola, it was a fear that we did not know. And we had many people who adamantly refused to take care of patients that might be under investigation. And it became something that we had to understand, and that understanding helped us as we prepared for COVID. One is that if people don't trust the equipment they're using, they're not going to do a good job, or they're not going to be willing to take care of it. Now, I'm not going to tell you that by the time we got to COVID in UVA anyway, that everyone was like, yes, the equipment works and we'll do whatever. People still were afraid of the equipment, making sure that, because we didn't know. And wrestling with that fear is where I think, and I'll let Dr. Oliver talk about this more, is where we made a lot of mistakes internally. And that's probably where I'm the most useful in thinking about public health, is our internal environment of the hospital. So when you think about epidemiology, we often think, in public health, we often think about large communities. But within those communities, there are other communities, and the hospital is its own little community. And thinking about how disease spreads within that community is important. And one of those diseases happens to be fear. And one of the things that I took away from our pandemic response, both with Ebola and then COVID-19, is the importance of healthy use of the words, I don't know. But this is the best we have right now. And you can see over time with our Ebola treatment gear, we basically used the same gear we used before. We didn't have any, we had lots of chances to test it. We made some modifications to make it a little bit cooler, but it was, we know from that disease that we have to be extremely careful, and there's a very rigorous process getting in and out of it. We started with not quite that extreme with COVID-19 as far as putting things on, but we used some of our same principles of donning and doffing coaches, which means we had someone there watching people take on and off their protective equipment. That slowly went away over time. We also got a lot more experience with donning and doffing, so like people became very comfortable with the process. But I would say that the end result of that learning of communication that we don't know, and then also respecting processes, led to the fact that our medical intensive care unit, which cared for hundreds of, I can't actually know how many, I know more than hundreds of patients with COVID-19, we did not have any transmission within that unit from a patient to a provider of COVID. We had some provider to provider transmissions, because that happens, and we had people who got it outside of the environment. But I would say that that's probably a unique experience that was not experienced throughout the country. And I would credit our ability to learn from Ebola in that response. And then as I think about preparedness that we should take forward from the 2010s into the future, it is that trying to understand that there are systematic barriers within our own organizations that lead to negative outcomes. But it all begins with trust in the system and the people that are taking care of the patients. And my assertion is that if we relied more on public health experts to lead the responses and less on policy and politics, we would end up having better responses. Public health individuals have a robust knowledge of several things that are unique to them. They understand the science of the disease, they understand the spread of disease, and they also understand the social factors that go into disease, both fear and the communication. And I think we have missed an opportunity to highlight the importance of that training as we think about other pandemics that we might be facing. And we're facing many public health crises right now that have pandemic-like qualities, from burnout among healthcare providers and healthcare provider suicide, which is at its highest rate globally ever. And that is a form of a public health crisis and pandemic that we need to see what could we have learned from 2010 to bring forward to that. And then to more maybe tangible things like monkeypox, which is spreading internationally now. And I don't think it'll be long before we have some other pandemic, which brings me back to one of my first points, which is I'm really sorry that I said I wanted to live through one public health emergency. I don't think I'm the only one who feels blame for that, but I would say that I've lived through too many now. And I would say that there are many lessons that have repeated themselves over and over again that we need public health experts to weigh in more on to prevent in the future so that we can have a more robust response going forward. And I'll yield the balance of my time to Dr. Oliver.
Well, I'm really glad to hear that it was Dr. Enfeld's fault, not mine. All these years since the COVID pandemic, I've been thinking it was my fault. When I became the state health commissioner in Virginia, at one point in 2018, I had brought together all the Virginia's what's called a centralized health department. So all the local health departments are part of the state organization. I brought all the local health directors to Richmond, along with their business administrators, and we had a meeting on something I can't remember about just now. But as part of the meeting, I decided, since I was a new commissioner and they didn't really know me, we do a little news conferencing, kind of get to know me kind of thing, and people could ask me questions and get an idea about where my head was at and where I thought we ought to be going, that sort of thing. And someone asked me, what keeps you up at night? And I said, oh, pandemics. And because, you know, it's not whether or not we're going to have a pandemic, it's when are we going to have a pandemic? And I'm desperately afraid it's going to happen on my watch. That was in July of 2018. And sure enough, it happened on my watch. The concept of being prepared, though, that has been a theme with both Dr. Hayden and Dr. Infeld is really, really important. In the fall of 2019, we did a simulation. We do these routines in the local health departments and at the state health department level where we practice an emergency response. We do it around hurricanes, and we also do it around pandemics. And we did an exercise. The exercise was for a flu pandemic that began in Wuhan, China, and was worse than the 2009 H1N1. And we practiced it. We had all kinds of logistical problems getting vaccines out across the Commonwealth, shipping things on trucks and trains, empty boxes. But in any case, we were doing all of this. We practiced that. And sure enough, we had to put that practice into action just a few months later, which is why when I stood up with the governor in March 7th, after our first case, March 7th of 2020, and said that we have practiced how to respond to this sort of thing. We know how to carry this out. We weren't just blowing smoke. We had really genuinely practiced it. And it's important that that kind of work gets done. And we had practiced it not just on the tabletop, but had the experience of the H1N1 pandemic as part of our lived experience. And when people had done quite a fine job in responding to that. I appreciate your comments about the politics, Kyle. I think, so there's 50 states with state health officials, 9 US territories. Of those 59 people, while I was a state health official, at least half of them, a little bit more than half, were either fired or forced out of office by their boss, the governor. I had the good fortune of having the governor, who was a physician, the Secretary of Health and Human Resources, who was a physician, and both of whom were sensible ones on top of it, so that when they came to the health department and said, what's the situation? What do we need to do? 9 times out of 10, they'd say, that's what we'll do. And that's one of the reasons why I believe Virginia did as well as it did in fighting COVID-19, especially if you compare it to the rest of the South, which did quite poorly, put it mildly. So we were fortunate in that regard. I don't want to tell you a whole lot of horror stories about COVID-19. You probably have it etched viscerally into your body. I want to focus more on lessons to be learned about how we responded. We had learned many of these same lessons with prior pandemics. Okay, Dr. Hayden talked about several of those. And with each one, it was very clear that the need to have public health be a robust system that could respond to these sorts of things was what we needed to do. There would be an initial influx of money after each of these epidemics or pandemics, and then the spigot would get cut off. We got tons of money around COVID-19 as well. And I'm here to tell you that while some of that money is still laying around, I'm pretty sure the spigot is going to be cut off. And that is going to be a huge problem. Huge, huge problem. We have a public health system that has systematic problems that we need to address. And I want to take that up in a number of different areas. The first area I want to talk about is in terms of capacity. Going into COVID, we were under-resourced and understaffed. Talk about data. I had 4 people in the department, 4, who were supposed to handle all of the data. We were getting lab reports on fax machines. We had to go out and hire a bunch of 1099 employees to do data entry, and they couldn't possibly keep up with the amount of data that was coming in every day. So when I stood up in front of the reporters and they would, blast holes in me all morning about how crappy our data was, all I could say is, yeah, the data's pretty crappy. But I couldn't, what could we do about it? We didn't have the capacity to really do what we needed to do. Building up the workforce, training that workforce, not just on the bread and butter public health sorts of issues, but on leadership and informatics, I think, and also communications is something that's really critical going forward. If we don't build that up now, the next pandemic, we will have difficulty in dealing with, as much difficulty, if not more, than what we did with COVID-19. We have to do something about our operations. And by operations, I mean the processes, the way we work. We need to flatten the bureaucracy. I came to public health out of clinical and academic medicine. I was here at UVA for 21 years in family medicine, a researcher, teaching residents, med students, that sort of thing, seeing patients. So I didn't come out of public health, and my mind was blown when I got into public health and I realized how bureaucratic it was. I was astonished. We need to flatten that bureaucracy so that and make it much more agile. We accomplished that to a great extent here in Virginia, and that's another reason why I think we did so well in our pandemic response. We did a system where every day we met across the Commonwealth, thousands of us getting together and online, talking about what was working, what was not working, and dealing with those problems in real time, being very agile about doing that. And that helped us with the pandemic response. It really increased our performance and increased our agility. So we got to build up capacity. We have to do something about our operations, becoming more agile in those operations. We also need to change our behavior. We need to do something about our actions as public health practitioners and public health scientists. We can't tackle disasters and pandemics and epidemics working alone. The work that was done between the health department and health systems like UVA was absolutely critical to our pandemic response. It wasn't just what you all were doing within the hospital walls, but UVA health system helped with the vaccination campaign throughout the entire community. Working together is really, really critical. And one of the ways in which I think we have to, one of the things we have to do right now is to build those partnerships now. One of the things you learn in emergency preparedness is that when you have blue skies is when you're supposed to put it all together, right? You get all the systems in place during blue sky days, because if you wait until the hurricane comes, it's too late. The same thing is true with pandemics. Okay, we need to build up the partnerships between public health, healthcare, and I would broaden that out to industry as well as community organizations and so on. We need to have that. One of the big challenges we had, if you will recall, in the pandemic response was a lot of vaccine hesitancy. You know, how did you come up with this vaccine so quickly? People didn't understand it. You know, mRNA research has been going on for decades, right? But all, you know, here's a vaccine that pops up that quick. How did you do that? I don't trust this vaccine. We were able to do a lot of work through community-based organizations, faith-based organizations, making them the ambassadors for the vaccination campaign. That could only have taken place because of the fact that we already had those relationships. So we could call a meeting of 3,000 pastors and clergy, you know, and from all kinds of denominations, and talk to them about the vaccination campaign and why they and the people that they serve needed to get a shot in the arm, and they could then turn and become the ambassadors for that campaign. So we need to do that now. We need to build up a common agenda around public health that understands that the creation of a healthy community is not the responsibility of governmental public health. It is the responsibility of governmental public health, healthcare systems, community-based practitioners, faith-based organizations, and industries in the community, local government, state government. We need to be all together, and we need to be together now around a common agenda of how do we go about improving the communities that we serve. We need to make this a strategic priority for all of those organizations. And we also, the last bit of preparedness I think we need to take care of, and a lesson that is learned from prior pandemic responses, is putting together the technology that we need to do that. I think in particular, we're in dire need of revamping our data infrastructure. I'm very, very passionate about public health and healthcare systems getting together and figuring out a way to share data. Healthcare systems have an interest in doing this because they're not just taking care of patients who show up within their four walls, right? These patients are a tiny fraction of patients. You know, if you deal with one diabetic patients, there's thousands more out there in the community that you serve, right? Knowing something about that community and those patients and what's impacting them helps you take care of people within those four walls. It also gives you the ability to be part of the solution for taking care of that whole community. Likewise, public health needs the immense amount of data that's collected by the healthcare systems to be able to figure out what's going on in the communities that we serve. We need to figure out ways to share that. I think about the upcoming respiratory illness season, right? I hope BDH is not relying on fax lab reports. So we figure out a way to do electronic. I mean, I know for a fact they got electronic lab reporting from most of them now, but we need to expand it. We need to do electronic case reporting. For the epidemiologists and the audience, you know, being able to get ideas in real time, some idea about the kinds of cases that are popping up in healthcare systems and clinics and so on would be really critical for the public health work that we have to do. So, you know, doing that, again, we need to do it now in the blue sky time before our next pandemic, and figure out a way to share that data that is, you know, protects the patients and allows figure out a data governance structure so that the data can, you know, UVA's data is UVA's data, but we can still utilize it in some way to help public health. And likewise, UVA can utilize data that we have to do things. This is a problem not just between healthcare and public health, but I think also within the, my own experience at the state government level, it's a problem with state agencies as well. So you look at something like data on children. BDH has a bunch of data, Department of Education has a bunch of data, Department of Criminal Justice has a bunch of data, Social Services has a bunch of data, Medicaid has a ton of data. None of that data talks to anything. It's all in silos. Whereas if you could put that data together and be able to query that data, it would greatly advance our ability to ensure that we have give a healthy start to children in the Commonwealth. So anyway, I'm gonna shut up there so that we have some time for questions from you all, both here in the room and are people in the webinar going to be able to ask questions?
Yes, we're going to monitor that. Thank you. Thank you so much.
Okay, I'm seeing no questions online. Are there any questions in the room? Yes.
Hi, thank you for the panel. It's really interesting to hear all of your perspectives. So I was kind of wondering a bit on the topic of like proactive epidemiology, right? Like a lot of what we're doing is oh, thanks. Thank you.
For our webinar participants to hear, yes.
So a lot of what we do is studying, you know, past pandemics and also, you know, trying to prepare for the future, but also it seems like proactive epidemiology is focused on treating a lot of times the symptoms as opposed to the causes. So how feasible would it be to look at proactive epidemiology from a causes perspective? And like, what shape would that take?
I didn't train as an epidemiologist or public health person. In my research, however, I did do what amounted to social epidemiology. I was very interested in social, cultural, and economic factors and how they impacted health outcomes. So I looked at things like residential segregation and mortality and prostate cancer, okay? Things like that, or effect of affordable housing on infant mortality, things like that. I think in people who do that kind of social epidemiology need to get beyond what I was doing 10, 15 years ago, where you look at something like some social factor like poverty, and you show that it's correlated with disease outcome X. That's sort of like, right? I mean, we all know that poverty and bad health outcomes are going to be related. Getting down to very specific factors in the social and economic environment and their actual sort of quantitative relationship to outcomes is really important. So when I was at the health department, if you go on to the VDH website, you can find something called the Health Opportunity Index. It has about 32 factors that affect health outcomes across the Commonwealth. And I said, you know, we need to get it down to the point where you can say, and we mapped it with this fancy GIS system we had. I said, we need to redo the filter so that what we actually map is legislative districts. And then I want to be able to go to delegate so-and-so and say, did you know that if you improved housing in your district by just 30%, you could decrease the infant mortality rate by X amount? Don't you think you ought to do something about that? Right? I think that kind of thing would be wonderful.
Other questions?
We have a question online. Archie asks, will artificial intelligence make a difference?
Short answer,
Yes. Yes. Next question. All right, so I will attempt to do my best here with artificial intelligence. So when we say artificial intelligence, I'm going to probably talk about machine learning and not large language models, though there's a lot of interesting things that you can do with large language models. So artificial intelligence is an overarching term that covers a lot of things. What can we do with it? Well, actually, I'm probably start with large language models. So we already know that large language models can be useful for us. Before COVID-19, there was a program called Flu Near You that was actually built on that arose out of the realization that they could use large language models to scan what people are putting into Google searches to identify where flu outbreaks were about to occur. So I think that is probably where we can start with artificial intelligence, because we are a society now that shares everything, except for, I guess, me. I don't have Facebook or anything anymore, which is kind of cool. But my wife shares everything that I do, so that goes in there anyway. So like that is, I think, is where we can be useful. I think we have an opportunity to, if we aligned all of our data well, is also to use machine learning to look at past mistakes, particularly as we think about supply distribution, vaccine distribution, et cetera. Because we know that we didn't do that perfectly around the world or even locally. Vaccine didn't always get to the right place at the right time. And that's an area where I think computers can help us think better about our problems. So instead of maybe artificial intelligence, maybe augmented intelligence is what I would use. Because I still think there's going to need to be someone prompting the machine to ask the questions that we need it to answer.
I'm not going to talk about AI, but really make the point that what we are finally achieving is better data to input into these models. One example, for example, is wastewater surveillance going on now across the country for not only for H5, but for other viruses. The most recent detection is an upswing in the enterovirus D68 detections, and that's a virus that can cause polio-like disease. So, I mean, I think that we have to marry these data manipulation strategies with actual high-quality data.
And before I pass it on, the one other part of that I would say is that our deficit here is that we have computer scientists who are really smart and don't speak healthcare, and we have public health individuals and physicians and nurses who don't speak computer science and they can't talk to each other. And so it's not even that we have great data that we can't use. We have groups of researchers and scientists who don't know how to talk to each other. And we need to actually increase the number of people who can make those connections so that we can blend that science.
Thank you. Other questions? Yes, Dr. Hayden.
Yeah. I would like to put you on the spot a bit. It's not just about vaccine hesitancy. There's a lot of misinformation.
Oh, yeah.
And false stuff. How do you deal with that in a public health level?
So vaccine hesitancy, I actually don't have a problem with, right? If someone walks up to you and says, I want to stick a needle in your arm and shoot this liquid into you, and then a sensible person should say, well, what's in it? Is it going to hurt me? I mean, these are factual questions that should be, and you should just answer them in that way. You should not, I don't think our approach to that sort of hesitancy is one where we should be judgmental or critical of that. We should just, yes, great question. Here's the answer. The misinformation and not just misinformation, disinformation that was spread and is being spread about vaccines, we have to deal with. And I in my mind, it's again about educating not so much the people who are spreading it as the innocent folks who are picking up on it and trying to educate them around it. So it's important that we learn how to give those messages. And I would say that folks who are really good at giving those kinds of messages, give those messages in the form of stories about people who are like the people in the room, right? Whoever it is you're talking to, it's got to be a story about people that they can relate to. So it needs to be that kind of message and not the scientific message. And there's a skill and a science to that kind of communication. You talk about healthcare folks and public health people not knowing data science. I actually don't think we know communication science either. And our knee jerk is to just start giving them all the epidemiology. I mean, that's like, I mean, they don't know what the heck you're talking about, right? So you need a message that is really designed to speak to them. You know, if someone is concerned, they don't want to wear a mask. There's no therapeutics, there's no vaccine. All we can do to protect ourselves is physical distancing and wearing a mask, right? But they don't want to wear it. Then you get a vaccine, and not, you know, one of the things that I was really big on, we were having huge problems in far southwest Virginia. Okay? I said, let's start telling people the best way, you don't want to wear a mask? That's great. The best way to get that mask off your face is get a shot in your arm, right? Change the way you talk about it is important. So we need to learn to talk differently. And the other thing I think we need to do is not just redo our message. We have to be clear on the messenger. If Tony Fauci went to Wise County, it wouldn't help. It might be counterproductive. But if a local pastor in Wise County got on a radio station and start telling people why they needed to get it back, it would have a huge impact. So you need a good message and you need the right message.
Other questions? Yes. Far away.
Hi, thank you. So I'm from Wise County.
Oh,
And I've worked in the Virginia Department of Health doing
great.
outreach and education on COVID-19 vaccines. I think you're right. But what I'm interested in is the interlay between policy, politics, public health, and then like flattening the bureaucracy. Can you speak to a little bit more about what that would look like? What do you think the bureaucratic holdups are in public health?
Bureaucracies are really good for some things like, you know, HR, finances. some logistical stuff. But we live in a really complex world. And you need to be able to maneuver a little more quickly. Were you working with the Lindenwood School Department during COVID?
Yeah.
So do you remember when we sent out those Chrome notebooks for doing registration for the vaccination sites? Did that work well for you?
Depending on the site.
You can be honest. So the normal functioning of VDH had been that if you had a problem with the technology that we had sent out for something, you would write an email to, well, you complain to somebody in the local health department, and they would write an email to somebody in Richmond whose inbox was overflowing with hundreds of emails from all over the Commonwealth. And maybe they would read your email, maybe they wouldn't. They read your email, and then they would say something to somebody in, say, the tech office, right? Office of Information Management. They might then say, well, you know, it's really not our issue. It's really VITA who gave us these tech books and Chromebooks in the first place. And then it would disappear into VITA's bureaucracy. And maybe somewhere down the line, somebody might decide to do something, and weeks to months later, something would happen for you, maybe. So I raised that Chromebook thing because when we instituted that agency forum, which I think is still going on in VDH, where people could come online on a daily basis and talk about what was working and what was not. And I remember distinctly someone saying online one day, those Chromebooks you sent to us are shit. And I said, and this is where leadership stuff is important, because the responsive leadership is, if I had shot that down, that would have been end of the discussion, and it would do away with the whole purpose of flattening that bureaucracy, which is to allow the front line people who are doing the work be able to tell you what's working, what's not working, and what we need to do the job better. Okay. So my response was Suresh, who's still there, who's the head of the Office of Information Management. Suresh, do we have any other laptops that people, or tablets that people can use for registration? Yes, I have several hundred. I can't remember what they were. And when can you get these out to folks? I can send them out tomorrow. So that problem was solved in real time, as opposed to what would have normally happened, which would have been weeks to months before it would have been resolved, if it got resolved at all. So that's what I mean by flattening the bureaucracy. Giving people on the front line the opportunity to say exactly what they need to do the job well, and the job of the people higher up on the hierarchy, if you want to look at the bureaucratic org chart, their job is to provide them with the resources they need, and that's it.
Thank you so much. We're out of time. Thank you all so much for coming. Let's give our panelists one more round of applause.